Can I help you? Hmm? Anything special? Yes. thumbs here from the gentleman here.
Oh, I see what you say. Okay, I think we will get started. Good morning, everyone. Thank you for making it down for, well, very bright and early at 8:30 in the morning. We have plenty of coffee, pastries, snacks, so do help yourself. I am Anna Dickinson, a senior researcher in the Science and Tech programme at Onward, and it is a pleasure to be chairing today's panel discussing the role of prevention and new technologies in boosting NHS productivity, which, with the Secretary of State speaking today, I think is a very timely topic for us to be discussing. It is my pleasure today to be joined by Neil O'Brien, Minister for Primary Care and Public Health, and also one of Onward's co-founders, Margaret McNab, Managing Director of the Health Division at Maximus, Simon Denegri, Executive Director of the Academy for Medical Sciences, and Richard Sloggett, who is the founder of Future Health Research and a former DHSC SPAD. The role of prevention and new technologies comes as a discussion point at a really crucial time. The NHS has just turned 75. It is facing unprecedented challenges following the pandemic, the backlog, staff shortages, and at the moment we currently have about 2.5 million people out of work and out of the economy due to ill health. Now, prevention can play a crucial role in addressing that. It can also play a crucial role in addressing the pressures the NHS is currently facing. Cardiovascular disease alone costs our NHS system about 7 billion, if not more, a year, and an even greater cost to the economy. So by introducing new technologies and preventative strategies, hopefully this panel, and I'm sure they will have a few ideas as how we can address that. So as after each of our speakers has shared their remarks, we will open it up to a few questions from the audience, and I'm sure you will be burning questions with everyone right here, bright and early. And then please follow along on Twitter at UK Onward. And also we are live streaming the event. So if any colleagues who weren't able to make it today wish to tune in, you can rewatch the session. So without further ado, Neil, over to you.
Well, thank you, and thank you all for joining in this early fringe. Everybody knows about the demographic challenges facing the health system and the relentless growth of pressures on it from an ageing population. And the two classic criticisms that people have of the health system are, firstly, that it doesn't do enough to prevent ill health, and it waits for people to turn up and need very expensive hospital care. And secondly, that it's not good enough at adopting new innovations and then diffusing them and using them at scale. Those are two classic criticisms, and they are two things that we are absolutely focused on working at DHSC at the moment. So in terms of the preventative agenda, now some of this is new technology, some of it is about just doing things differently. So if I think about things like smoking, in the 1970s, about 40% of people used to smoke. When we came to office in 2010, it was about 21% of people used to smoke, and that's now down to 12.9%. So a huge reduction in smoking. Again, brought about by, firstly, doubling excise duty on cigarettes, but also by a series of other things that we've done and are continuing to do. So, for example, we are at the moment taking something that was tried successfully in a number of local authorities and scaling it up, which is swap to stop, where we are going to send 1 million smokers free vaping equipment to swap over to a much safer technology. We're also taking another innovation that was tried here in Manchester, actually, where people were given a £400 voucher if they stopped smoking in pregnancy, hugely reducing the number of women who smoke in pregnancy, massive long-term benefits, and we're now scaling that up so it will apply everywhere in the country. Again, it's all about making the health service kind of hassle-free and easy to use, and making it a health service that comes to you rather than you having to come to it. So, for example, if I think about blood pressure, hypertension, we are, through the new Pharmacy First service that we're introducing at the end of this year, going to hugely expand the amount of blood pressure testing that we do, because we know if we find undiagnosed hypertension, that is potentially going to save someone's life. It's going to stop heart attacks further down the line. And so we're going to be hugely expanding it through pharmacies. We're going to start working with employers to do more testing in the workplace, and we're looking also to start to bring it into more community settings too. But we are also in prevention trying to exploit some of the newer technologies as well. All of you have got a smartphone in your pocket. Increasingly, people are using health apps. Increasingly, people are using the NHS app as well. So this year, for the first time, more people booked their vaccination over the winter through the NHS app rather than ringing up 119. And to build on that and to go with the grain and to lean into those changes, we are starting to do some interesting experiments. So, for example, in Wolverhampton, we've handed out a huge number of wearables, basically Fitbits. People can monitor their exercise through an app, they can monitor their eating, and they can again get incentives and rewards for improving their health. And an incredible proportion of the people of Wolverhampton have now signed up to this. So using the new technology, doing more on prevention, and particularly doing more on screening, where the NHS has been too weak for too long. So 2 years ago, we announced that we would create these community diagnostic centres, a new type of place you could go to close to you to get potentially life-saving diagnostics. We've built 119 of them in just 2 years. We've seen 5 million people to get important diagnostics, and they're typically in cottage hospitals, in communities, in the high street, much closer to people than having to go to a massive type 1 A&E. We're also using the app to make things just easier to do. So, for example, at the moment we have the NHS health check. We've had it for a few years. At age 40, you get offered this test of your cholesterol, your BMI, your other health metrics. But only about 40% of people actually take it up. And so we're going to introduce from next spring the NHS digital health check, where you can do all those questions on your phone. You can get posted a cholesterol text, or you can do a pinprick test on your finger, and then we'll show you where you can get access to a blood pressure monitor in either the waiting room of your GP or perhaps in a pharmacy. And so we just want to drive up this kind of screening and preventative activity by making it just much easier to use. And we are also trying to use it to tackle health inequalities as well. So again, in Manchester, they pioneered the lung health check, taking buses with screening equipment on to the poorest communities in the city. And we're now rolling that out at scale for all the people who are kind of smokers or ex-smokers in the most deprived areas. And that is inverting health inequalities. We're going from having about 1 in 4 cancers detected at the early treatable stage to about 3 in 4. So a huge number of lives being saved by that. And by other technologies like FIT testing, which is the so-called stool sample. So increasingly, if you turn up at your GP, and the rollout is nearly complete now, if you turn up at your GP with the symptoms of bowel cancer, instead of being referred on for a consultant appointment for this, you'll get a simple test, you do it at home, you post it off, and only about 2% of people actually need a follow-up. So we're completely changing that workflow. We're making it much more efficient. We're screening out a lot of people who don't need to worry and making sure that we focus our expensive resources on those who actually need it. And we're committed also to doing more on cancers across the board. For example, we're in a very late phase kind of mass trial of a thing called Gallieri from a company called Grail, which is a test for 50 different types of cancer. We've committed to buy 1 million of those tests, assuming that it works as we hope. So doing much more to prevent, using technology in prevention, but also using new technologies more generally to drive efficiency. We can see that the only way to save the NHS is to make it radically more efficient. And that cuts at all levels. So it's partly about management technology. So we're rolling out electronic bed management across the NHS, so people can constantly see which beds are occupied, which need turning around. We can improve the flow through hospital. We don't get ambulances parked on the entrance ramp, get people out more quickly. Also, basic things like the electronic patient record, which will be fully rolled out in all trusts by spring of 2026. I mean, this is something that clearly should have happened a long time ago, and we are now absolutely driving home. And we're doing a lot through technology to improve the use of people's time. The NHS is Britain's biggest employer, the biggest people business. We've got to use people's time more efficiency by giving them the tools that they need to do the job right first time. So, for example, we now have a fleet of about 100 pieces of equipment to do robot surgery. You know, a lot of you will have seen them, these huge arms where your movements as a surgeon are effectively miniaturized into tiny, tiny robot arms. And so your huge hand gestures of sewing up a vein are then being translated into these incredibly precise little sutures in a vein or a tiny piece of tissue. And that hugely reduces failure rates in surgery, reduces the need for people to come back. And in other things like strokes, we are rolling out a technology called Brainomics in stroke networks, where by feeding the scans of people who've got a suspected stroke into AI, you're getting much more accurate diagnosis of what the problem is much more quickly, and that is taking up the proportion of people who survive with almost no impairment or no impairment at all, up from about under 20% to nearly half, which is transformative. So putting these technologies in the hands of people, increasingly making use of data as well, all levels, to increase accountability, because I do think there is not enough, as well as not enough technology, there's not enough accountability in the NHS. So in my field, in primary care, in dentistry, we're going to start publishing data on the performance of each ICB, which I get every month and which is not published at the moment. We're going to start publishing, or rather we already are publishing, through the Fingertips website. I don't know if any of you have ever been on Fingertips, but you can now go on there and look at the performance of your GP surgery compared to all the others in its area and the national average. And so you can choose if that is the right one for you and see how they're doing. And at the level of the ICB, we are trying to insist on reducing variation, publishing the data, and that is our great mission, to create and use data in a smart way to try and drive up performance and reduce the unnecessary variation and failure you see in some places. So, on the one hand, more prevention. On the other hand, new technology, getting the NHS to be quicker scaler and adopter of these innovations. These are the things that will drive productivity, improve patient satisfaction, and just make the NHS a much more hassle-free service. There's also truly a health service for the first time, not a hospital service that waits for you to come to it, but a health service that gets out there and helps to improve the nation's health. Thank you.
Thank you, Neil. And yes, completely agree. I mean, the prevention strategy is about lessening the burden on the NHS, because once you're already there, you are already unwell, and there is already a repercussion to that. Margaret, may I turn to you next?
Yeah, thank you, Neil. Really interesting points. I'll pick on a few of those as I go through. For those of you who don't know, Maximus is a global provider of health, employment and customer services. So we've got operations in the US and outside. And we sort of approach this debate from a slightly different angle, because we don't provide clinical services. So we're kind of on the outside of the ecosystem. But we do provide preventative services, so many of the things that Neil's referenced around smoking cessation, weight management and healthier lifestyles we already provide across the country. And we also provide the access to mental health at work support service for the DWP, and we provide about 6,000 medical assessments for the DWP as well. So we're on that sort of not direct services. And I think there's three areas I really want to cover today. I think we really believe that prevention is the key. Although you didn't say it, Neil, I think we're probably, hope we're kind of moving to something that's more of a national prevention service. And many of the things Neil's mentioned, I think they're very good in their own right, but how do we bring them all together in one system so that the individual can participate and be more empowered and to take responsibility for their own health? So we really welcome the government's focus on prevention, and I think it's an opportunity to seize. So we know from work that the Tony Blair Institute did in recent years that 99% of all health spending goes on treatment, but yet we know that it's 3 to 4 times more productive if you spend that money on prevention. So it's really about how do we progress that prevention agenda. We had an example, we work with the local authority in Birmingham. We worked with people on weight management programs, and over a course of 6 months, 93% of people completed their programs with us, and 88% said that they'd improved their lifestyle. So that's very much about how people can, before they get to the treatment phase, can take responsibility. I think there's also a point, though, about how we become more connected across government. So, policy doesn't start and end with the NHS and the DHSC. There are other things around that. So it's how basically you can use other parts of the system to help people take responsibility for their own health. I mean, an example would be that we know that poor quality work, I feel like I'm competing with the rain now. Yeah. Poor quality work and lack of access to, physical activity and stimulation, and lack of stimulation at work can have a detrimental effect on your mental health. And we know that disabled people are twice as likely to fall out of the workplace than non-disabled people. So there is this need in the ecosystem to give support. And I think finally, picking up on a point Neil made around technology, we're really only scratching at the surface. about what can be achieved in tech and AI revolution. And we really need to push ahead with the agenda to get better outcomes for our citizens. So I think it's very encouraging that there are lots of trials and there's, we're already starting the agenda, but the pace of change is relentless. And, there's a case to say you can put guardrails around the revolution, but in many ways we have to kind of get on with it and take and seize the opportunities that are there to make progress, both for kind of health of the NHS and its transformation, but also to help people to take more responsibility for their health and have a healthier population. So I think it's really about how do we really support individuals to take responsibility of their health as part of the system and through our programmes and technology, and also just be more joined up across the system. So that's all I wanted to cover today. Thank you.
Brilliant. Thank you, Margaret. Thank you for battling the rain. We are doing our best. But in what you said, I think the comment on the cross-departmental and sort of wider ecosystem role that we each have to play was crucial. I mean, yesterday colleagues and I were at a panel where they said in the NHS alone, amongst their workforce, 1 in 3 people are also carers in their what limited free time they have. And so the impact that does become cumulative. But Simon, may I turn to you next? Please.
Yes, thank you very much indeed, and good morning everybody. Lovely to be here. Very atmospheric tent. Reminds me why I don't particularly like camping. So anyway, it's good to be here, and it's good to have the chance to visit the Conservative Party conference again. So for those of you who don't know, the Academy of Medical Sciences is a 25-year-old national academy. We bring together a fellowship of just over 1,400 of the most influential scientists from across the UK, several thousand early career researchers and emerging research leaders that we've supported with career schemes. And we work to do a few things really. One is to influence policy, working with policymakers and others across the sector. We obviously support people in their careers, as I've just said. We foster public involvement and public dialogue across health and science, and then we obviously also work with global partners to forge relationships to improve the world's health. And our vision is good health for all, supported by the best research and evidence. And I wanted to first start off with a sort of contextual statement, really, which is I think it's no accident that we have both a world-class National Health Service and we have a world-class life sciences sector, because these two things act together, and when they're at their very best, when those things work together really, really well, we can see the results of that. And we saw that during the COVID pandemic, when millions of people came forward to test vaccines and look at other therapies which benefited us all. And we see it every day in terms of what's reported in the newspapers. Some of you may have seen the stories yesterday about the artificial pancreas, which is actually funded by the government and others, National Institute for Health Research. So we see that constantly. And it's going to be very, very important that we enable that relationship to become ever closer and more integrated in the future if we're going to maintain the pace of technological advance and innovation, which means that patients will be better off, and also the UK will be better off in terms of health, but also economically. But it is a fragile relationship at the moment for many, many reasons, as we portrayed in our report earlier this year called Future-Proofing UK Medical Health Research. And I don't have time to go into all the reasons why, but I'll try and touch on some of the things that we need to do. Last year, there was a report done for the Prime Minister by the Council for Science and Technology, which I think underlined everything that Neil has said about the need to rebalance our health system towards prevention and early intervention and empowerment, and also talking about the role of technology and innovation in actually helping to do that. And it does really present a major opportunity. I think I would underline also what Margaret has said is technology is only good if you empower those who are going to use the technology and the end user. And again, that's a point I'll come back to. And the challenge is that we face, even with that technological tailwind behind us, are massive, as I'm sure you will know from your own personal experience. In a short while, we'll be publishing a report on child health from the years 0 to 5, and some of the statistics of that are quite stark and quite worrying. So a quarter of our children between the ages of 0 to 5 are obese, and of course that level of obesity increases in deprived areas. So we have a lot to do around the prevention and the early intervention agenda if we're going to stem that tide and actually enable our health service and our social care services, which we haven't really mentioned yet this morning, to cope better with those challenges. So in the Academy's view, we have to do 4, I think, foundational things to enable us to build that system of prevention and early intervention. The first is that the policies that we implement, the policies that you are discussing today in the conference have to be rooted in the evidence. Absolutely must be rooted on what we know to be the best evidence at that time. We also have to harness data and novel methods, and we have to link the data that's being developed around the determinants of health. And it's only by doing that we build up a really accurate and good picture about the interventions and the work that we can do to improve things. We also have to invest in public health practice and research and integrate it really fully into the health system. And lastly, we have to develop the next generation of public health researchers and practitioners in order to carry the torch forward. I think there's one positive I would just mention and one worry I have, both which about people, because I've been in many debates about technology, and I'm as big a fan of it as everybody else. But the thing that we perhaps don't do is invest enough in having a culture across our health and social care system which is going to support that innovation in the best way. So my positive is that, having done a little bit of work with integrated care systems and integrated care boards, is the appetite to grasp the innovation agenda is absolutely massive. They really do understand, I think, what this can mean for local populations and to meet local needs. And they are the ones who are close to the ground and want to do it. And of course, they need support and they need help to do that. But I think I haven't seen that positivity quite so much in the past. So that fills me with great hope. My worry is whether we really are developing the workforce in the way that we need to support innovation and to enable them to confidently talk about it and use it with their patients and carers and families who come through the door. And obviously, we have particular worries about the decline in the number of clinical academics, but that's just one aspect of the workforce agenda which we need to address. My very last point, Anna, is that none of this works unless we empower people. And it's really our very strong belief in the Academy of Medical Sciences that the way you do that, first of all, is you involve people in the design of these products and the design of these innovations. And I'm going to just finish off with an anecdote about how sometimes innovation can go wildly off stream unless you do involve the end user. So I happened to be observing a research panel which was looking at grant applications, and it was a panel primarily of researchers and health professionals, but there were some patients, and they were looking at different grants to do with arthritis, a major issue in this country, and I'm sure some of you in the room have experience of that. And they were considering this application, and they got very, very excited about the fact that it included the proposal to develop an app that patients could use alongside the research, a so-called self-help app. And it was going to cost quite a lot of money. But the enthusiasm in this room was incredible. But it took the patient to say, it's all very well you spending tens of thousands of pounds on that app, but with my condition, I can't actually use an app. So I think the patient is there to give us a reality check. And it's really important that they are a part of the partnership in the way that we think about how this system sustains what they need and meets their needs and priorities in the future. Thank you.
Brilliant, thank you. And I completely agree on having I think it's not just patient-centric, but also people-centric research, even before people become patients. Now, Richard, I'm going to turn to you, and you have the challenge of competing with the vast array of topics that have been covered already.
Yeah.
But over to you.
Yeah, I did think this when I saw my name on the list, and particularly going after such an esteemed group. You write your notes, and then you have to basically rewrite them. So the NHS has not been very good at doing prevention. It's not been very good at adopting new technologies, and it's not been very productive. So what role can prevention new technologies play for a more productive NHS? Needs to have an understanding of why we haven't made as much progress as we should have done in the past. There is huge potential on this agenda, as this panel has said. There is an amazing array of new innovations and technologies. I remember when I was in the DH, we would have cohorts of people coming and looking at the new inventions and innovations. Some of the creativity and scientific discovery is absolutely incredible. But we need to sort of understand the journey we've been on and why it hasn't maybe been as successful as it could have been, because by understanding the challenges, we can then try and work out what a better design framework for the adoption of innovation might actually look like. And I know there's some work going on in government, NHS England at the moment, on this specific topic, because one of my reflections is the system is incredibly complicated. So the complexity of the system is almost itself a barrier to the adoption of new technologies. We have a number of schemes set nationally, locally, regionally, particularly when you throw in innovation pods, that mean that there's a lot of small-scale stuff that goes on, but it never doesn't really germinate into something more substantive. So why haven't we made the progress we should have done? There's a number of really obvious things that anyone who's been going to a health tech-related panel in the last 10, 15, 20 years will know. So we don't fund technology. We don't have the level of funding of technology in the NHS that we need to. The NHS has often balanced its books on the back of the fact that it doesn't invest in tech, and it also doesn't invest in tech in a multi-year way. It invests in a single-year way. The system's interoperability doesn't necessarily function as well as it could do. Systems don't talk to each other. There's privacy, security concerns. We don't have the workforce capability. We have legacy systems and vendor lock-in. We've got a digital divide that's potentially emerging. We've had cybersecurity concerns, and now we've got to manage things like the bias and artificial intelligence. So these are incredibly complex problems, and partly explain why we haven't necessarily made the shift that we could have done. And if you go back to the creation of the NHS in 1948, the design of the system was that it would be a system that would deliver prevention alongside treatment. It's in the 1948 white paper. It just hasn't. It's the bit of the system that we've never managed to deliver on. But it's not all as negative as I say. Why is that? Well, I think we learned a hell of a lot through COVID, and we quickly moved. And actually, there's some brilliant work that was done across the system on particularly things like data management, operability. Look at some of the work that was done around the vaccination programme. The publication of that data was incredibly important, because what it meant was resource could be directed into areas and regions where the uptake was a bit more complicated. We were getting data in real time, which for the NHS is an amazing thing, because the amount of time that you would be looking at data in the system at the centre of government, and it would say, well, this is what was going on 6 months ago, last year, and you're sort of going, well, that is not helping me in a system which is, at the moment, we have a waiting list of, 7.7 million people. We need better real-time data and information. So the pandemic was a real kicker on that. The other thing I thought that the pandemic did, which has been picked up by other panellists, but I think is possibly the most exciting bit that we haven't yet really cracked, is connecting with people on their own health and improving people's own understanding of their own health. So health literacy, and I was reading a paper on this, 42% of people are unable to stand information about their own health. So 4 in 10 people will be given health information that they are unable to interpret. And when you put numerical information into that, that goes up to over 60%. That, for me, feels like something that we need to try from a government perspective or politician's perspective and from a system perspective, really, really work at. The NHS app's been downloaded by 30 million people, well, 30 million downloads. I think there's some really good opportunities to work out how we can connect people into helping them understand more about their health and their management of their health. And actually, that might be a route in to start to do prevention in what could be quite a relatively low-cost way outside of the traditional structures where the complexity of the system often doesn't work in the favour of what you want to ultimately achieve. Because often what we do in policy is we focus on the centre of government and what the centre of government needs to do. And actually maybe the role here is about providing better information, tailored information, personalised information, which we can do now through some of the innovation, through some of this new technology. Now against that, what we've got to try and do is we've got to try and manage the issue of the digital divide and health inequalities and how we go about doing that. But I don't think that should block us from moving in that direction. The key is to try and get a design framework in place which makes sure you can engage with your citizens in a multifaceted way. So it's been a very, very difficult time for the NHS. It's a very difficult time for the NHS right now, and it's been a challenge for it to pivot towards prevention. But I think there are some new opportunities emerging and some things that we have learned in the last 3 or 4 years, which give us a chance to maybe have a go at doing this in a more accelerated and different way.
No, completely agree. I mean, there's a lot that we've covered in this panel so far: the cost of ill health to the NHS, the role beyond just Department of Health for covering this agenda, and the role that different departments can come in, transformational potential of new technologies, the impact of inequalities, the digital divide. But it is now an opportunity to open it up to the audience. So please, hands up. We have roaming mics, so bear with us as they do find you. Yes, we'll take lady in the front in the blue, the lady in the second row in the blue, and then the gentleman in the third row who's got his hand up. So just bear with us while a mic arrives.
Hi, I'm Bernie Muir, County Council at Surrey County Council and Chair of the Health and Wellbeing Board in Surrey. My question is about collecting data that actually means something. A lot of data is collected. It's often not compatible with other systems, so they can't overlay them, which means we can't interpret them. Particularly in the NHS mental health services, it's an absolute nightmare trying to get data out. The other side of it is cross-organisational data. So let's take mental health, for instance. If we don't have enough workforce for CAMS, those people go into adulthood with severe mental health conditions. At that point, we don't know where they pop up in the system, if they're dropped and bounced. They might come up in the health system. They might come up in the criminal justice system. We don't know, therefore, with a prevention budget, where we are succeeding and where we're failing, because the data doesn't cross organisational, not cross hospitals, not patient records, but the buy-in, particularly in my experience with the NHS mental health system, with providing data, and they seem defeated into whether or not they can measure outcomes. I think they can, specifically when people pop up, follow their pathway. And the other part of the data is we don't often know when people are dropped, let alone bounced. So I think that's a big part of prevention. Just one more point. For instance, in Surrey, I think the public health budget is second from the bottom. People think we're highly privileged. We've got one of the third most deprived wards in my division, and it's equal to anything I did when I was working in Poplar. So, just because we seem to be a rich county doesn't mean we deserve the public health budget. If you sink in a very expensive place like Surrey, you sink fast.
Okay, thank you. The lady in the second row in the blue, please.
Thank you very much. Alison Railton, Kidney Research UK. I wanted to ask about the major conditions strategy, which has prevention at its heart. Kidney disease wasn't one of the 6 disease areas mentioned to be included in the strategy, despite a patient population of 7 million and a cost to the NHS of 6.4 billion annually. I just wondered, will there be benefits and advantages coming out of the strategy to address other conditions beyond those mentioned as part of the 6 areas?
Perfect, thank you. And then just the gentleman over there.
Hi, my name is Ishmael from McNab, Learning Disability Charity. So my question is towards where we talk about technology is like when we're making GP appointments. And I think sometimes GP appointments is quite challenging for people with learning disabilities, especially when it comes to e-consult. Because, like, for example, my GP surgery is like when you're making appointments, they don't want to book it over the phone, want to book it for e-consult, first come, first serve. And it's quite a difficult thing for people with learning disabilities when it comes to technology. And I want to know if how the government or anyone who's in charge of the NHS around making reasonable adjustments for people with learning disabilities.
Okay, perfect. So quite a lot to cover in that. The data barriers and potential major condition strategy and beyond, and the impact that can have, and challenges of accessibility. Neil, could I turn to you first, and then we'll...
Yeah, they're all great questions. So on Bernie's question about cross-organisational data, it's something we are hugely enthusiastic about, and the kind of data linking projects between different silos are something we're very keen on. For example, in drugs, which is one of the things I work on, trying to track people from their entry into the criminal justice system, their treatment in prison, so their treatment outside prison. We have not been able to do that in the past. We are building the systems. There's one called BOLD that we have just built that allows us to do that in mental health. It's Maria Caulfield's part of the department, so it's not something I'm as familiar with, but absolutely I know that it's the sort of thing that she is looking at. In terms of Alison's question about the major condition strategy, yes, there will definitely be benefits. So as you know, it's focused on the biggest killers, but the sort of things we're doing to tackle those biggest killers have also some generic quality. So a big part of it, as you have seen from the interim paper, is about the kind of common core of prevention and screening more generally. So the same sort of things, obesity, smoking, etc., drive all of those major conditions and other things, including kidney issues. And the kind of de-siloization agenda is also relevant as well. So one of the good things that happened, as well as all the terrible things during the pandemic, is we got a bit away from the excessive siloization of different people and different specialities and people not talking to each other or knowing each other, that we've seen a bit in secondary care, and that is something we're keen to build on in the major conditions strategy when it comes to its final form. And on the really important question about mental health, people with difficulties using electronic systems, particularly in primary care. So one of the things that we are doing at the moment in primary care is this big £240 million investment in new technology for GPs. A part of that is going into new phone systems so that people never ever get an engaged tone when they ring up their GP. GPs are absolutely queuing up to get that. And it's also a big investment in digital systems. But what we see where people have got those really good digital triage systems in primary care is that increasingly, particularly the kind of younger population and those who can use those systems do, and they interact with their GP in just the same way that they would expect to interact with any private sector business. You can post any time of the day and night your concerns, post pictures, asynchronously, not at that moment, get a reply so that the workflow is much better. What we see is that as well as patient satisfaction being much higher, what tends to happen is that older people and those who can't use their systems find that the phones have been hugely freed up, or the ability to walk in and be seen is hugely freed up, because all that demand from those who can use the digital systems is going down that channel instead. So it's much easier to get through for those who really do want or need to use the phone or something simpler. So absolutely, and there is, to the legal point you raised, there's an absolute requirement that GPs have to see those who want to face to face or have phone systems. You can't just say, the only way to contact us is through the internet. That's very, very clear. And if people have examples of bad practice being followed in some places where people are excluding people, let me know, because the rules are incredibly clear. We're very enthusiastic about people doing more digitally, being much easier to contact your GP, interact with them online, but that is not to say that we're going to take away those other vital channels that people need and expect to be able to use.
Brilliant. Sorry, we can't hear you, and we've got quite a few questions, so could we wait for follow-up questions, please? Could I give Margaret the chance for you to...
Yeah, I just wanted to pick up on Bernie's point. I mean, we're very often in a position of responding to procurement for family, child, adult weight management and integrated lifestyles. And it's quite hard as a provider sometimes to work within the envelope. I mean, that's a kind of a current situation, Bernie. So I absolutely recognise that. So it's, we know we've got really... there's lots of providers have good programs that could respond to the needs you have in your population. I think it's important to note as well, it's kind of a broader point, picking up on Bernie and the gentleman from McNab and other points made earlier. It's not always about clinical resource either. There's lots of other parts of society that can help. So, we regularly work with football clubs and health coaches, or in the McNab situation, in our employability service and access to mental health. We have people who facilitate, so you can provide non-clinical resource to help people access service. So I think it's important not to only talk about clinical resource. And then the final point, I think, on data is really important. I mean, we've got a huge, rich, longitudinal data set in this country. And I think it's really important to understand actually what is worth collecting from a national basis, because otherwise you get a bit overwhelmed by everything that's there. And if you think like a medical insurer, and I've worked for lots of different providers and medical insurers, a medical insurer would bite your hand off for that data set. But an insurer would look at it from a risk profile. So, could we be using that data to minimise risks rather than always seeking more funding? Is there a more intelligent way to use it? And I think the final point I would make on that, I think probably Richard and Simon both made the point, there's something about the transformation journey we're on in the NHS and enabling everyone in the NHS, and probably more important, leaders making decisions, how to use data, because it may not be how they started their career. This is kind of a new thing that some managers have to deal with, is how do they manage data, how do they use data to inform their decisions. And I think there's more requirement in a system that's under pressure to be able to do that quickly and intelligently.
Yes, indeed. Simon or Richard, did either of you two want to jump in before we take in more questions?
You go first, Richard.
That's very kind. Thank you, Simon. So people who heard me speak yesterday on the major conditions strategy, I've seen a slight pivot from where we were in January to where we are today. And that pivot is moving away from major conditions to multiple conditions. And it's about 1 in 4 people have more than 2 health conditions. And if you're over 85, and there's going to be 1 million more people in the UK over 85 by 2035, they have 80% of people over 85 have more than 1 health condition. So it's trying to, I think, set a design framework for the system, which is about how you manage people outside the traditional silos of where healthcare has operated. I think where we were in January was we'd had a lot of political commitments over the last 3 or 4 years to update national plans, and a view that those were not on their own, that those were in too much of a traditional model. So I think what we're seeing is an evolution in the design framework of policy, which I think will help those with conditions, multiple conditions. So I think there's been a slight pivot. That's my read on the situation anyway. On Bernie's question, which is a really, really good one about how you get the right data out of the system and how you join it up. There's some really interesting work that I was made aware of up in the Northeast about how you make every contact count. So waiting lists are obviously really, really high, and waiting times in certain parts of the system are also high, and people are waiting for a long, long time. But often what we do is we let people sit there, and we don't communicate with them. And we have a captive audience to have a conversation with and a discussion with and get them to fill in information and to get more feedback and information. And people often, when they trust the National Health Service, they want to engage with it. Is there an opportunity, again, to have better two-way communication when people are waiting on a waiting list or in a waiting room, which actually can get a primary care network or a hospital to say, actually, we think you might be eligible for a screen or a vaccine or a such and such, which actually then can actually start to tackle and improve the health and make that connection a little bit better. So you take something which is a real problem, which is high waiting list, but you actually try and maximise the impact you're having with people on that. So those were just the 2 points I wanted to come back on.
Brilliant, thank you, Simon.
Yes, a couple of points. So, first of all, on the major condition strategy, I can completely understand and applaud the reasons why you might do that as a government, and there's lots of merit in it. But I think Richard's right. The pivot that we have to make is to be thinking more as a nation about multimorbidities, because that's where the challenge is, and that's where we can start to put in, I think, prevention and early intervention strategies that actually act across many of those things. So I think that is the pivot that we have to make as a nation. I sort of really empathise with your point, Bernie, and some of you may have seen there's quite an active stream of letters in the Times at the moment about data, and you could have written those letters 5 or 10 years ago, because in some senses it feels as though progress has been slow. But I think there is progress. I think in some parts of the country you're getting better sort of sharing between sectors than others. And I suppose that's one of the interesting things that we have to get better as a nation at. You do get very good practice in certain areas of the country, but we're not very good at lifting it up and moving it across and actually helping others to learn from that good practice and to adopt the same sorts of innovative and early adoptive process. And just on the GP point, because I think this is a really fundamentally important thing about access for patients and access for the public. And I absolutely agree with what Neil has said, but I think there is a danger, and even from my own GP surgery, that the message that is given out is, we are only accessible between these hours and through this system, and if you are not part of that, you can feel excluded. It can be almost a prevention for you coming forward. So I think we have to work really, really hard at enabling those people who already feel disadvantaged to feel that the service is still there for them and that there are ways to access it. They may not have a phone, they may not have internet access, but they can still use it. I'm not too sure that message always gets across. I mean, I went to my GP surgery a few weeks ago. It doesn't even have a letterbox now. And there are still people who post letters. What does that say to someone who doesn't have that sort of technology?
Yeah, and it ties into your point earlier about designing services around patients and for their needs. Could we open it back up? Oh, lots of hands. Could we take the lady at the front in the green, the gentleman right at the back in the blue, and then there's a lady in what looks like a red and black top in the back corner who's got her hand up here.
Hi, Sophia Greenblatt. I'm from Cancer Research UK. We talked a lot about prevention on this panel, which is great to hear, as my brief is prevention. But I worry a little bit about the fact that we often talk about all of these amazing innovations and all of these amazing things that we can do on prevention, but we balk at the cost that you have to put up front. For every pound invested in prevention, you get 14 pounds back. So the return on investment is huge, but we balk at the upfront cost, when in reality, if we don't start preventing illnesses now with an aging population, we're going to get into further and further trouble when it comes to people with multiple conditions, with preventable illnesses, and with cancers specifically. So I wonder what the panel thinks we should do to, Neil, for you, I guess, what would help convince your colleagues, at least in the Treasury, to invest that money up front?
Okay, and then the gentleman in the back corner.
Thank you. Paul Goulden from the International Longevity Centre UK. We've recently launched our Global Health and Prevention Index, and the UK comes 16th out of 121, which is great, but we want to make that better. My question sort of follows on in how we actually celebrate the success of prevention. So a falls prevention service will prevent neck or femur breaks, but in essence you're trying to measure something that hasn't happened. So my question to the panel is, how do we actually use data and technology to celebrate the success of prevention? And I think, coming on from the previous question, to actually make the case for more investment in this.
Okay, brilliant. And then just in the back, second row there.
Thank you so much. Laura from Parkinson's UK. So yay to all of the other charities in the room. So apologies for all the questions that we're giving. I wanted to ask two questions. Fascinating discussion, but two questions in particular. The first is about the long-term plan. And a number of the speakers talked about how the NHS workforce isn't necessarily prepared to roll out this technology. So in line with kind of the workforce plan, what do you think the NHS and the government needs to do in order to make sure that the workforce is ready for kind of technology and AI and all of those things that are coming through? And then the second point is around prescription charges, which actually, as a chair of the Prescription Charges Coalition, we think prescription charges could potentially help to prevent a lot of people potentially going into hospital because they can't afford the charge, and it is a barrier to keeping people well. It's something that the government hasn't necessarily engaged with long-term condition charities on, and it would be good to maybe have a conversation about whether there could be something there, because obviously Scotland, Wales and Northern Ireland don't have prescription charges, yet England is the only country in the UK that does.
Thank you very much. So two sides of the investment conversation there, one on the upfront cost, one on prescription charges and the impact, and then the workforce plan and the long-term plan and how those two correlate. Neil, could I turn to you first to sort of unpick a little bit on the investment side and the challenges that not just the HSC but also the NHS faces?
Yeah, so they're all really good questions. So on this point about how does one make the case for more preventative activity, I think it's partly a sort of data question and showing about the joining up to the question that was asked earlier on about joining up data sets so you can show the financial gain you're getting from doing the preventative work. And we're always keen to do that. But I think a thing that I am very, very interested in is a suggestion in the Hewitt review recently about having a budget for prevention and using that as a way of having some discipline about the short and the long term. There is always this pressure in the NHS since 1947 to to do things that work in the short term and therefore not invest in the things that work in the long term. And so I think that is an intriguing idea that we'll need to think carefully about. To the question from a gentleman from the Longevity Centre, great service about how you prove what happens with the dog that didn't bark in the night, as it were. And again, it's a data and analysis question. You can use natural experiments, can sometimes be very compelling, where you can see the difference that an intervention at the local level will make, and because, of course, of the kind of increasing devolution of the system to ICBs and their ability to do those experiments, we can use those to tell that story. In terms of the long-term plan, absolutely, the first ever long-term plan, it is something I'm quite proud of. The NHS has never before actually bit the bullet and explained how many more people it will need over the coming years, partly because it's pretty stark in the face of an ageing society. And that plan, which I encourage people to have a look at, is very detailed in terms of all the different categories of people, all the different types of specialists that we need. And it's also a plan in terms of how we do things differently and more productively, and don't just use the conventional categories of staff, but think about how we can do things in a more multidisciplinary way. But I'm afraid on the prescriptions question, so always happy to look at all these things, but it does surprise people when you tell them that only about 1 in 10 prescriptions is actually paid for in England, because of course the young and the old, those who are pregnant and those on low income don't pay, and there's also a variety of schemes to reduce the cost of people who have multiple prescriptions. So I appreciate that is a disappointing answer, but it is the case that when these things were abolished in Scotland, for example, they did have to find quite a lot of money to do that. It did not pay for itself, as some people would like to present it as doing. And so for us, it's always the choice about resources. It is that 1 in 10 who are paying, it is focused on those who can pay, and that is quite a lot of resource for the NHS that we then put into things that do save people's lives. So it's a difficult decision. We'd love to make all these things free, obviously, but we have choices about how we spend our limited budget, and that is where we have come to.
Thank you. Margaret, did you want to jump in on
I just a couple of points I wanted to pick up on. I mean, I absolutely agree. You know, we're definitely behind the prevention agenda, and it's also about how we prioritise. We work a lot with families, so it's not just always about individuals. Sometimes in the early years with obesity in children, about educating families and that unit about how to do things together. I think the point about the data at the back, I mean, how I would suggest it's used is to validate some of the business cases for bringing initiatives forward, and also promoting the value of these initiatives in the local community. I think the point you made about equipping managers and the management in, I think my view is that the NHS doesn't have to be an expert on everything. I think there is this kind of private provider, public sector. I think we're reaching an era where we have to have a full ecosystem where, the public sector and the private sector work together, where the expertise lies. So I wouldn't suggest, yes, it is about equipping some managers, but it's also about the partnerships, I think, that should be forged between the public and private sector to make, take full advantage of the opportunities that are out there.
Indeed. Simon, did you want to jump in from there?
Yes, please, Anna. So I'm going to just focus on one of the questions, even though they're all very good. I wanted to focus on the workforce one. I think one of the things I was very pleased about is, I think both in the NHS mandate now and in the workforce plan, there are very clear statements about the importance of training the workforce around research and innovation. I think that's the first time we've really seen some solid statements about that, and something that we can all build from. So 3 cheers for that. I think the additional things that we can do are we can give, I think, health professionals more time to do research, innovation, and even more time to talk about things like technology and patient data to their patients. And some of the other things that I've been involved in, like Genomics England rollout, one of the difficulties was not the technology, the infrastructure, it was enabling nurses and doctors to talk about the importance of this innovation with their patients in a confident way. And so we sometimes, I think, forget about that downstream dissemination point, which I think if we were in the private sector, we just would not do that, because it's our market. We want to give the best chance of success. And then I think the other thing that we need to do is, I think, invest in certain parts of the workforce where there are not the skills. Invest in people's mobility, researchers' mobility from private to industry to NHS. but also invest in areas like clinical academics, which, as I referred to earlier, we've got less clinical academics than around 2007, and these are people who will provide leadership in the system and help to draw things together. They're not the sole solution, but they're a very, very important part of the way that we address these.
No, I agree, and I think the point on upskilling or making sure that clinicians and nurses are confident speaking about areas such as genomic, the work that Health Education England have done has come on leaps and bounds and played a crucial role in this over the last few years. Richard could...
Yeah, just very quickly, and I just wanted to sort of join up the first two questions really. A percentage of spend on something is quite a crude lever, but it's probably the best lever we've got to try and do the thing that we want to do, which we haven't necessarily been able to do, that we've always wanted to do. And then the question is where you set the level of spend and what you then critically. It'd be interesting to see on your ILC paper how what you've classified as prevention, because obviously one of the big challenges is how do you define it and what do you include in it. So if you could join those two discussions up, I think you could have quite a fruitful piece on how you're classifying prevention and what you're spending on it. There's a good proxy for this, which is what happened in mental health. So mental health, one of the big challenges was always Cinderella service. Over the last 10, 15 years, what's happened is that there was a lever put in at clinical commissioning group level, which was to spend a certain proportion of your budget on mental health, which meant that CCGs had to spend it on mental health. And actually it did have a benefit in how mental health services were then prioritised at a local level, which was not necessarily previously the case. So we do have a case study example of where this has had some benefit. And
also backed up by a service standard as well. So
exactly.
You had to do certain things as well. And again, you might use that as a metaphor for what you want to do in terms of prevention.
Yeah. So from a policy perspective, I think there is something in this to certainly explore, and Hewitt, as Neil says, to obviously look at this.
Great. I think we have time for one or two final questions, if there are any hands. There's a lady at the back in, I'm going to say, a trench coat, and then, ladies in pink at the front. You've been selected by Simon. So,
sorry.
Hello, my name is Corinne Turnbull, and I'm here as a patient representative with a bit of feedback from the Royal Osteoporosis Society, so again, another charity discussion. And the Sunday Express and Royal Osteoporosis Society have been running a Better Bones campaign of late, and it's about the fracture liaison service, which is really the gold standard in bone health. However, fracture liaison services are only in 50% of England, and therefore there's a postcode lottery. We know that this is a highly effective and very cost-effective way of preventing downstream impact in terms of hip fractures. My question actually, other than saying, could we not have this in 100% of the country, was actually about the data and the accountability, because the fracture liaison services that we have don't have any compulsion to report on the downstream, what happens once somebody has been referred. And it really seems to me that that's a lost opportunity. So I'm thinking that a very small way of increasing the prevention, increasing our data and our understanding, would be to make that a compulsory piece for those fracture liaison services.
Okay, thank you. And then the lady in the...
Hi, my name's Alexis. I'm from the Northern Health Science Alliance. And our recent report shows that a life science supercluster across the north of England could bring in £16.52 billion a year to the UK economy, and also double the number of jobs in the sector by 2040. We've got great digital tech in Manchester. We've got vaccine development in Liverpool. So we really want to see a commitment from the government to build this supercluster, as it is the key to new and preventative technologies in the NHS. And as Richard was saying, we need to build on those gains we made during COVID and make sure that they're not lost. Thank you.
Oh, was there?
So my question is just,
Sorry.
I think it's really important that we build the life science supercluster across the north, and I'd like to know what Neil thinks about how we can do that and harness the power of the north, as we've got, the Golden Triangle with Cambridge down south. So how we can really, as a key part of levelling up, I suppose. Yeah. Thank you.
Okay, great. So again, another question on data, and then our life sciences ecosystem. Could we, just in the interest of time, sort of keep our answers fairly succinct across the panel? So, Neil.
We can keep them short. So on Corinne's question about osteoporosis, my answer is simply either I can't commit to anything today. I hear what you say. It strikes me as an extremely sensible suggestion, and I think that we will look closely at it. So a very good point. And in terms of the point about the NHSA, when I was previously a Levelling Up Minister, I'm extremely enthusiastic about it, really enthusiastic about the things that are happening around Northern Gritstone and all the kind of translational stuff, as well as being a very good health policy. It's an extremely good levelling up policy in terms of getting more out of our research strengths in this part of the world. Obviously, Manchester also hosts to one of the research accelerators as well, so lots of focus on trying to do that. And if there's more that we can do, very keen to do that, because I do think it's, as well as being a really good focal point in terms of like life sciences industry and the like, it's also potentially a really good way of tackling this problem that we keep referring to on the panel about the difficulty of getting new innovations into the NHS at scale, and having a few slightly fewer kind of loops that people have to jump through in order to get things tested at scale, and to have a story, as you guys do, about why this is a compelling place to test things and to try things, I think is a really good thing. So I think I've been following it since the start. I think it's an excellent thing. I think keen to build on the kind of vision that you got.
Great. Margaret, did you want
I'm probably just going to echo what you said. I'm afraid I can't answer the question you've raised, but I think the issue about just generally in terms of integration, I think the more we can integrate across the system, I think the more productive and effective we'll be. Fantastic. Richard?
Yeah, I mean, I'm a huge NHSA fan. I worked with Hakim, who ran it about 5-6 years ago, and when I was working on it, it was just so inspiring to see the level of potential economic growth that you can grow in region. It is basically absolutely intrinsic to levelling up, because health is everywhere, and we have a national health service, which could be a real enabler for the adoption of innovation and growth and local jobs. And how we continue to push on that is, I think, something that you need to continue to drive forward, because it does feel like a really, really good health and economic connection and opportunity.
Perfect. And Simon?
Yeah, so actually, Salford, which I'm sure is in the Northern Health Science Alliance, if I remember rightly, is one of the places I was thinking about where, linking data has been done very well with things like the Salford lung study, and as a really good exemplar for others, and that goes back some years, so it just shows you we were doing some really good things then. I mean, if the Science Minister, George Freeman, was here, we would be talking about the importance of building up clusters around the UK, and as an academy we would be very supportive of that. Clearly that requires investment. The other thing it requires is having good leadership in place to do that, and also, again, going back to a previous point, it requires skilling up researchers and those within those clusters to be able to build bridges and to be mobile between sectors and to build up experience and understand how to work together. That's where the momentum comes from, as much from the people as putting in the investment. So absolutely think we should be doing more of that.
Okay, thank you very much to all our panellists. I have a few thank yous just as we wrap up. Thank you, first of all, to Neil, Margaret, Richard and Simon. Thank you to Maximus for supporting this event. It's been a pleasure to work with you. And thank you to you, our audience, for not only attending and being here bright and early at 8:30 in the morning, but also for bringing so many questions. So if you could join me in a round of applause, I'll return you to the rest of the day. Thank you.